Josh, you have anything to add?
Well, believe it or not, I actually am a trained medical oncologist, but I have much less experience recently with patients than my colleagues here, so I don't think I'm going to be able to add much to what they've already said. I spend more time with robots now, so.
So the thing about this question is it actually is a source of whole-day symposia and longer now. And there are things that we haven't even begun to touch on, but I do want to get them out there, and I'm curious if any of our panelists, co-investigators in the front rows want to jump in. But firstly, with regard to testing, everything that's been said is exactly right. It's not a test like screening for blood pressure, where you just want to put every person through it for a variety of reasons. If you test a lot of people even who don't have a gene abnormality, but you process a lot, you actually have a risk of false positive findings for one thing. The second thing is that, and I loved it, you said this, that any test we do, we should do when we have a plan for its implementation. And this is a theme in medicine all the way from the beginning of med school to the end. Just doing a test because you want the answer actually is very rarely sufficient reason, because it leads to more questions and uncertainty and anxiety. The third thing, though, is that at least in June, when we go to ASCO, we will get the first big public results of a new class of drugs called PARP inhibitors, polyadenosine ribose polymerase inhibitors. We'll just call them PARPs. And these drugs, which are being tested in a variety of centers around the world where there are concentrations of patients who have BRCA mutations, and the patients have been willing to go on these trials, have been really remarkable. It's not violating any rules to say this. The drugs are active. How active they're going to be, how they fit into the normal treatment algorithms, whether they replace or displace conventional therapy, all that is yet to occur in terms of testing. But knowing BRCA status isn't critically important today, as you heard, but there's a real chance that, like HER2, it will matter. The dilemma is, and this is what the reporter I mentioned at the beginning was getting at, is what happens when you start to have drugs that are really only good for 2, 3, 4% of the population. Who develops them? How do you incentivize the world? And our incentive here is clear, right? We want to do good. But when you start talking to shareholders and so forth, it gets a little more complicated. And we have to figure out ways with philanthropic support to make all this work. We're not in it for profit, but we need to at least have a sustainable machine. And you're going to hear a lot of discussion, I think, on this topic after ASCO because of the challenges that the PARP inhibitors will present. So I wonder if any of you in the audience in the front want to jump in and say anything. There are people in this room who've given these drugs to people, right?
They're exquisitely I think this is a real story about how medicine is changing so quickly. In 1997 is when we started doing the genetic testing, and at that point, people said, why are you going to test? What are you going to do with the information? There's no proof that you can do anything. That was 1997. I think then studies came out to show the effectiveness of preventing future cancers, perhaps with different surgeries, removing the ovaries, being life-saving. And now we're on the verge of really saying there are specific treatments, cisplatin chemo or PARP inhibitors, that are different and exquisitely effective. So that's in 11 years or 12 years. That's a lot of progress.
How many PARP inhibitors are we're hearing about 2 at ASCO, if I'm not mistaken, but I think there are in the neighborhood of, does anybody know?
3 or 4 companies.
How many in development now? 3, 4? 3. Right. So it's a really nice story. It's not a revolution overnight, but it's a rapid evolution, and there's a tangible benefit. And the other comment I'll make is, and I heard the plug for this about counseling, some of us have the blessing or curse of living in places where we don't have a choice. In New York State, I cannot do genetic counseling. I can't order a test from Myriad Genetics. I can't send the BRCA test off. The patients by law have to be counseled by a certified genetic counselor, and there are many other states in the country with this, and there are some that do not